Hello friends, today we are going to learn about intraoral examination in fabrication of complete denture. This is the part 2. I have already posted part 1 including the extraoral examination in fabrication of complete denture. You can see that in my previous videos. So, intraoral examination involves evaluation of existing teeth, mucosa, saliva, residual alveolar ridge, interarch space, hyperplastic tissues, hard palate, soft palate, muscle and frenal attachments, tongue. Now we will study each of this one by one in detail. Existing teeth. We have to examine the condition of existing teeth, as how many teeth are present, what is the condition of these teeth, are they reliable for support or not. Mucosa. We have to learn many aspects of mucosa such as color, condition, thickness of mucosa, which all will affect the stability of denture. First of all, color of mucosa. The mucosa should have healthy pink color. If there is redness, it indicates inflammatory changes which will lead to ill-fitting denture. If we will make the denture in that inflammatory condition only, once the inflammation goes, the denture will not fit the patient. Condition of mucosa. House classified mucosa into 3 classes according to the condition of mucosa. You can make out from that only by the name. The class 1 is healthy mucosa, class 2 is irritated mucosa, and class 3 is pathologic mucosa. The names itself explain all. Thickness of mucosa. Variation in thickness of mucosa make it difficult to equalize the pressure under the denture to avoid soreness. This means if the thickness of mucosa in different places is different, then it is very difficult to equalize the pressure in each and every area and it may cause soreness. House classified thickness of mucosa in 3 classes. In class 1, the normal uniform density of mucosal tissue is present. Class 2 can be of 2 types. The first one is soft tissue have a thin investing membrane and are highly susceptible to irritation under pressure. And the second one is soft tissues have mucous membrane that are double the normal thickness. Class 3. Soft tissues have excessively thick investing membrane filled with redundant tissues. The next one is saliva. Quantity and viscosity of saliva plays an important role in denture stability. So, saliva can be classified into 3 classes. In class 1, normal quantity and quality of saliva is present and cohesive and adhesive properties are ideal. In class 2, excessive saliva is there which contains more mucus. And in class 3, very less saliva. That condition is also known as xerostomia. So, why it's important to study saliva? The thick, ropey saliva alters seat of the denture because it accumulates between the tissue and the denture. And patient with very less saliva, the condition is also known as xerostomia, as I already mentioned, shows poor retention and excessive tissue irritation. Residual alveolar ridge. In this, we'll study about arch size, form, remaining residual ridge, etc. Arch size. Why to check for arch size? Because denture bearing area increases with arch size and increases retention. And discrepancies between the arches can lead to difficulty in teeth arrangement and decreases the stability of the denture. Coming to the classification of arch size, class 1 is large, as you can see in the diagram. It is ideal for retention and stability. Class 2 is medium. It provides good retention and stability, but not as it is given by the large size arch. Class 3 is small. In small arches, it is very difficult to achieve good retention and stability. Now, let's study about arch form. The form of the arch plays a role in support of a denture and tooth selection. It is classified as class 1, square as you can see in the diagram. It is somewhat squarish in shape as you can see in the diagram as well. Class 2, tapering. As you can see in the diagram, it is tapering from anterior side. And the class 3 is ovoid in shape. The name itself explains it. Ridge contour. The ridge should be palpated for bony spicules which produces pain on palpation. So, we should check the ridge thoroughly. Ridge contour is classified into 3 classes. The class 1 is high ridge with flat crest and parallel sides. This is the most ideal type of the ridge. Class 2 is flat ridge as you can see in the diagram. And class 3 is knife edge ridge. Ridge relation. The positional relation of mandibular ridge to the maxillary ridge is known as ridge relation. In simple terms, we can say it is the anterior-posterior relationship between the ridges. Angle classified ridge relation into 3 classes. Class 1 is normal, in which maxilla and mandible both are present in same parallel relation with each other. Class 2 is retrognathic. In this, maxilla is present ahead of mandible, or you can say mandible is present a little bit posterior to the maxilla. You can see in the diagram. Class 3 is prognathic, in which the mandible is ahead of maxilla as you can see in the diagram. Ridge parallelism. Ridge parallelism refers to relative parallelism between the planes of the ridges. The ridges can be parallel, non-parallel, and it is easy to set teeth in parallel ridges. Ridge parallelism can be classified into 3 classes. In class 1, both the ridges are parallel to the occlusal plane, as you can see in the diagram. In class 2, the mandibular ridge diverges from the occlusal plane anteriorly, as you can see in the diagram. And in class 3, either the maxillary ridge diverges from the occlusal plane anteriorly or both the ridges diverge from the occlusal plane anteriorly. Interarch space. Interarch space also affects the fabrication of complete denture. Decrease in the interarch space will make teeth arrangement very difficult. However, the stability of the denture is increased in these patients due to decrease in leverage forces acting on the denture. Interarch space is classified into 3 classes. In class 1, ideal interarch space is present to accommodate the artificial teeth. In class 2, excessive interarch space is present, and in class 3, insufficient interarch space to accommodate the artificial teeth. Ridge defects. Ridge defects include exostosis and pivots that may pose a problem while fabricating a complete denture. Hyperplastic tissues. The most common hyperplastic lesions are papillary hyperplasia of the mucosa and hyperplastic folds. Treatment for these lesions include rest, tissue conditioning, and denture adjustments. Surgery is considered if the above-mentioned treatments fails. Hard palate. Hard palate is also classified in 3 types. The first one is U-shaped. It is ideal for both retention and stability. You can see the same in the picture. This type of hard palate provides maximum stability and retention. V-shaped. Retention is less as the peripheral seal is easily broken in this type of hard palate. Flat. In this type of hard palate, reduced resistance to lateral and rotary forces is present. Coming to the soft palate, it is also classified in 3 classes. Class 1. It is horizontal and demonstrates little muscular movement. In this case, more tissue coverage is possible for posterior palatal seal. Class 2. Soft palate makes a 45-degree angle to the hard palate. Tissue coverage for posterior palatal seal is less than that of class 1 condition. And in class 3, soft palate makes a 70-degree angle to the hard palate. And the tissue coverage for posterior palatal seal is minimum. Palatal throat forms. The relationship between the soft palate and the hard palate is called palatal throat form. House classified palatal throat form into three classes. Class 1 is large and normal in form, relatively with an immovable band of tissues 5 to 12 mm distal to the line drawn across the distal edge of the tuberosities, as you can see in the picture itself. Class 2, medium sized and normal in form with a relatively immovable resilient band of tissues 3 to 5 mm distal to a line drawn across the distal edge of the tuberosities. Class 3 usually accompanies a small maxilla. The curtain of soft tissue turns down abruptly 3 to 5 mm anterior to a line drawn across the palate at the distal edge of the tuberosity. Lateral throat form. It is also classified into three classes. The first one is deep. You can see the same in the diagram. In class 2, the depth is moderate, and in class 3, it is very shallow. Tori. Tori is abnormal bony prominences present in the middle of the palatal wall and on the lingual side of the mandible in the premolar region. To prevent injury to the thin mucosa covering tori, adequate relief should be provided in that region during CD fabrication. Tori is classified into three classes. The class 1 is tori is either absent or minimal in size. It does not interfere with the denture construction, so we need not to bother about it. In class 2, tori are of moderate size and mild difficulty in denture construction is present. Class 3, tori are of large size and it is very difficult in denture construction. Surgical contouring or removal is required. Border attachments. House classified border attachment into three classes. Class 1. Attachments are placed away from the crest of the ridge. There is at least 0.5 inches distance between the attachment and the crest of the ridge, as you can see in the picture. Class 2. Distance between the attachment and the crest of the ridge is around 0.25 to 0.5 inches. Class 3. Distance between the attachment and the crest of the ridge is less than 0.25 inches. You can see the same in the picture. The attachment is very near to the top of the ridge. Tongue. First of all, let's talk about the size of the tongue. If the tongue is large, then also it is a problem, and if it is a small, then also it is a problem. How? Let's see. Presence of a large tongue decreases the stability of the denture. Hindrance occurs due to impression making also, and the tongue biting is common after insertion of the denture. And if the tongue is small, then it does not provide adequate lingual peripheral seal, which will affect the stability of denture. House classified tongue sizes into three classes. Class 1. Normal in size, development and function. Sufficient teeth are present to maintain this normal form. Class 2. Teeth have been absent long enough to permit a change in the form and function of the tongue. Class 3. Excessively large tongue is present. All teeth have been absent for an extended period of time, allowing for abnormal development of the size of the tongue. Insufficient denture can sometimes lead to development of class 3 tongue. Tongue position, which was classified by Wright. The class 1 is the tongue lies in the floor of the mouth with the tip forward and slightly below the incisal edges of the mandibular anterior teeth. In class 2, the tongue is flattened and broadened, but the tip is in normal position. In class 3, the tongue is retracted and depressed into the floor of the mouth with the tip curled upward, downward or assimilated into the body of the tongue. Thank you for watching my video. Friends, if you like my video, please subscribe my channel and ring the bell icon for latest updates.